Well, welcome everybody. Thank you very much indeed for attending this Strategic Planning Commissioning seminar on Scenario Generator. My name's Claire Cordeau. I'm the Executive Director for Healthcare at SIMUL8 Corporation. I was involved in developing Scenario Generator when I was in the NHS, and I'm very pleased to be working with SIMUL8 now, helping people to use it. What we wanted to do today was to look at what Scenario Generator does, and for those of you who are just picking it up for the first time, or perhaps are trying to refresh your knowledge, remind you what it is, what it does, show you some of the features, and help you get started. We intend this to be the first of several training sessions that we'll be running. We hope it's very useful for you. There's a chat panel on the right-hand side of your screen. If you have any questions during the simulation, the presentation, please do just ask them and I'll answer them as we go through. So welcome again. I'm going to go through just a little bit about who we are and our experience, why simulation is a useful technique in healthcare, and then get on to Scenario Generator, some examples about how Scenario Generator has been used, and then we'll get on to the exercises in how to get started. So just a few words about Simulation Corporation. We're a simulation software company. We've been around for 20 years, and we aim to make our software easy to use, very fast to learn, so that you can concentrate on the complexity of the problems that you need to solve rather than which buttons to press on the simulation. We are specialists in health and social care. We have a specialist team that brings together some of our knowledge in working in practice in both health and social care, but also our simulation expertise. So we're used to working with health and social care colleagues to solve health and social care problems. These are some of our users. As you can see, we're active all over the world, and we've had a very good relationship with the NHS in the UK, and Scenario Generator was a tool developed with the NHS Institute for Innovation and Improvement, and we had a strategic partnership with the Institute to support people to use simulation and modelling really through Scenario Generator. So what is simulation? Well, what simulation does is it models a flow of events. Now, in this case, it's very often a flow of individual patients, but of course it could be a flow of blood, it could be transplants, flows, it could be supplies, looking at linen to beds, that sort of thing. But if you have in your mind a dynamic process map, if you like, a flow of events going from service to service with rules as to how people use different services, how long they're spending in each of those services, how much they cost, what the time is between the treatments, and if there's not enough resource, then how long people are waiting until that resource is freed up and they can get into the next part of their pathway. So if you imagine that sort of that flow, you can see that you could apply that to all sorts of things in health and social care, whether that's small-scale operations, looking at an inpatient unit, for example, or a whole system, whether that's emergency departments, bed modelling, clinical operations, whether it's disease pathways. It's the same sort of technique that you can usefully apply to, and the point of it really is that provides you with a virtual system that you can ask questions of. So if you're wanting to test out what might happen if you bring in a service improvement, or you want to reconfigure your system, or you want to provide more care outside of hospital, for example, you can test it out in this virtual simulation and see what might happen, which means that you're not going to hurt any patients as you do it, you're not going to disrupt any staff, you're simply asking a question, and we find that makes people braver about the sorts of solutions that they want to test, and it gives you a graphical visualization so that you can engage people in these sorts of questions and some of the what-ifs. So what I'm going to do is just show you very briefly a little simulation, just which describes really what simulation is. And hopefully on your screen you can see our doctor's clinic simulation. Now what this is showing is people coming into a doctor's clinic, and here's the entrance here, and they're going to see the receptionist, and then there are two doctors available. There's a clock on the right hand side which is showing the time, and we're going to run this simulation 9 to 5. Now, to make the point, I've set it up a bit like a spreadsheet, which is what people very often use for modelling type of questions. So I've set this up as a fixed arrival, so we've got people coming in precisely every 5 minutes, and when they see the receptionist, they're going to see that receptionist for precisely 3 minutes, and then they're going to see each of the doctors that are on call. They've got precisely 10 minutes, and you can see my values here. So let's set that running now. And hopefully you can see patients moving through this simulation, waiting for the doctor, and then exiting. Now it's all going fantastically smoothly at the moment because of course we've regulated it so well. Everyone's turning up every 5 minutes. Oops. And they are and they're seeing the staff for a precise amount of time. So that's our perfect system. And when we get to the end, we can see how many patients who've been seen, and they've all taken just over 19 minutes to get through the system. And what we know is that that's not really like real life. So let's do some experimentation with this. I'll just reset the scenario. And I'm going to change this to put some variation in here. So I'm going to say that patients will arrive on average every 5 minutes, and we're going to use an exponential distribution. There's going to spend 3 minutes with the receptionist again, but it's going to be this time an average of 3 minutes, and then they're going to spend an average of 10 minutes with each of the doctors. So it's a very small variation, but we'll just run that through and see what the impact is. So again, running through Monday to Friday, 9 to 5, and you can see immediately that people are starting to queue up for the doctor. Now this is not the sort of queue that you'd probably be worried about in real life, but nevertheless, just putting in that variation has had that effect. And if you can see sometimes people are queuing for the receptionist. So I'm just going to run that through to 5 o'clock on a Friday, and we can see now that the average time you spent in the system is now 33 minutes. We've got a few people still waiting for the doctor here, a few people with the doctor, so we haven't quite had everyone seen, so the doctors will stay on past 5 o'clock. And you can see that it's taken about an hour for the person who's had to wait the longest time from coming in at the front end to leaving at the end. Now that's a very simple simulation, really just to show you the sort of thing that you can expect simulation to be able to help you with. So we're looking at variation, we're modelling a very simple system, and you can get those kinds of results. Now that's a useful thing to have. It's got that risk-free element, as I explained before. It's using some of your data and assumptions in a very intelligent way so that you can understand what the impact of any change might be. It allows you to compare different sorts of solutions, and it shows you the passing of time, which is something that a spreadsheet can't do. And so when you're looking at planning for healthcare, you've got some very difficult decisions to make and some very difficult, very tricky parameters really to juggle with. So you'll have a finite budget and you're probably trying to reduce the amount that you're spending. How much resource have you got? You might have got the budget, but perhaps you don't have the right staff in the right places. How are you going to make that change? You may not be able to control your demand as the population is aging. You can expect more people to be coming to your service. So the thing that you can play about with is how long people wait. So you can sort of try and make people wait a little while for your service so that you can cope with the volume. However, if people wait, of course, their health outcomes might deteriorate. So how long is it reasonable for patients to wait? And it's going to be the combination of all of those different parameters that will enable you to make the best decision, the most realistic decision with the resources that you have. And of course, when you're looking at a whole system, there will be financial winners and losers. So there are costs related with all of those things, but of course some of the benefits will accrue to some parts of the system and not to others. So I don't think anybody ever suggested that planning for healthcare was an easy job, but this software can handle all of those parameters, which is why it can be useful to use. Now, coming on to Scenario Generator, what we're using is that same technology, but if you think about that small clinic, I want you to take a mental step back now and think about using that same technology for strategic planning in health and social care services. So looking at a whole system and enabling you to think through how that works. Now, what Scenario Generator does is give you a framework for understanding that whole system. We've got some default data in there so that you can start to test scenarios immediately. So you can start with some templates that we already have, and the idea is that you can get started with simulation in some of these complex areas even if you've never used simulation before. As I said before, this was developed with the NHS Institute when it was around and was distributed at that point to all PCTs. Part of the purpose of this webinar now is to make sure that those people who are no longer in PCTs, who didn't know that they had access to a license, can get access to a license from the NHS, which is really a legacy from the NHS Institute, and get started yourselves. At one point, when the PCTs were around, it was being used in about 80% of NHS England. It's still used in Scotland health boards, and it's also used in a number of other countries. So, excuse me, how it works is we're taking activity from demographic projections and the factors that influence demand. So, in particular for healthcare, we're looking at age-related, age-banded disease prevalence and how you're, so if you're looking at your population changes over a number of years, then you associate that with the age-banded disease prevalence, and that you can understand how that's going to influence your demand in particular areas of healthcare. And that demand then flows through a set of services representing the different patient journeys that might take place depending on their need, and gives you results. And the aim of it is to enable you to ask some of those whole system questions and to configure it to ask for some of your own what-if questions. So what we've given you is some templates to help you get started very quickly. Data's available so that you can use it rather than going to look for your own, and then you can amend it and refine it as you go through asking your questions. So a better way of looking at that probably is as the functional map here. So on the left-hand side, you've got your population, and you can look up your local populations, and I'll come on to how you do that. The version you have is actually a slightly older version of Scenario Generator, which the Institute, before its demise, allowed us to give out to anyone in NHS England. The more updated version has actually got the CCG and local government populations in it. So you can put in your population, your disease prevalence data, and we've uploaded that from the Royal College of GPs annual prevalence survey, so it's covering the whole of the ICD-10 range, and that then populates a set of pathways. So we have 5 generic pathways in Scenario Generator. In fact, social care is a more recent addition, and the maternity pathway is populated by the female age-banded population and fertility rates. So there's a direct link there between your female population. Mental health is populated by the ICD-10 chapter for mental health, and the rest of the activity is split between planned and urgent care. we've used actually HEST primary diagnosis data, which tells you what against which ICD-10 code emergencies will arrive as a way of splitting that. But all of these parameters are user configurable, so you can change any of the assumptions in the model. Now, each of those pathways is made up of a set of steps which represent the services in those pathways. You can cost those steps, you can give them a duration, you can associate capacity with them, and as the activity flows through the system, so it generates results which show you how much activity is in each place at each time, how much it's all costing, and whether there are any constraints, any bottlenecks in the service. That's your default, if you like, of your whole system, and what you can do is is to change the population and see how that might change the flows over time. You can change the flows through the system, you can change the duration of the lengths of stay, and you can change the capacity to ask some of those strategic questions. I hope that makes sense. I'll just remind, and I can see there's a few additional people who've arrived. There's a chat panel on the right hand side of your screen, so any questions that you've got, please just upload them there, and we'll answer them as we go along. Okay. Now the simulation can run for up to 50 years. That's probably a little bit outside the time frame that most people are planning for, but 5 years, 10 years are useful time frames to run for. And the results that you get are the activity by all the services, by all the pathways, the costs, any queues, how your resources are being utilised, and you can compare one scenario against another. So the benefits are that it's a tool that helps you to understand the whole health and social care system flow. And what we find is that as people look at their overall flow in a system, they start to understand how it's working better and why the current state perhaps has got some problems. They usually find out things that they didn't realise were happening, and so it promotes the understanding of the system. You can look at the impact of population change. You can segment your population, so you can model individual age bands, you can model different disease groups, so that you can take a sort of helicopter view into parts of your system and see how it's being used, but relate it to the overall system. And you can test your service redesign initiatives, reconfiguration initiatives in that virtual system to see the impacts. And of course it's all risk-free. So I wanted to come on now to talking about a few example projects, just to give you some ideas of how people have been using it and the sorts of decisions that they've been making with it. And then I'll come on to showing you Scenario Generator itself. So some of the example projects are looking at individual condition pathways, so stroke care, for example, has been one, dementia care, depression, looking at a larger section, so looking at care of over 65s, both health and social care, end-of-life care, virtual wards, and I'll show you some of these examples as we go through. So just to start off, East Riding PCT modelled the impact of introducing the BNP blood test on heart failure. Now they were concerned about the cost of that, but when they modelled through the cost of the test against the likely impacts as their population aged, they could see that actually they would be saving money, which was not something that was immediately obvious, and it was something that they needed to model through and get some results for before they felt able to adopt the introduction of the BNP blood test. And in actual fact, the work of East Riding PCT was taken up by NHS Improvement, and a similar model used with a number of different PCTs who were also not adopting. And it's now in NICE implementation guidance. So that's an example of a disease pathway and an intervention in a disease pathway which was able that individual PCTs, individual commissioners could localise to understand the impacts. County Durham, a similar kind of area, but looking at stroke care. In this case, their simulation question was what happens if we treat all patients at risk with preventative drugs. And so they modelled that through, and of course, as you can see from the results, actually it does cost more in the initially, but in fact by the time you've run that through in 5 years' time and you've looked at the overall impact and you've looked at the outcomes for that population, you do have savings of over $1 million. Now again, that wasn't immediately obvious by looking at the initial introduction if you just looked at the cost of the drugs, and being able to model impact over a number of years can help with decision making about an investment at a particular point in time. Now, both of these last two examples were examples where there's good clinical evidence for adoption, but actually the operational evidence wasn't immediately obvious, and so this kind of technique is very useful for that kind of operational evidence. I'm just going to refer to an interesting project that was carried out in Gloucestershire, which was the NHS and the County Council working together, looking at a whole system model for health and social care. Now, they were partly using this to try and understand how the flows worked across health and social care to enable them to work better together, but they wanted to also look at some specific scenarios to test. So they were looking at how the population was going to change and how that would impact both health and social care. And they used Scenario Generator. They built in some additional pathways. So I told you that there were a set of pathways that people already in the tool that people can start using. What I didn't say is that you don't have to use all of those pathways, and if you want to, you can create additional pathways. So, for example, if you were looking at in this case at social care pathways, in this case, Gloucestershire County Council wanted to separate the pathways out into older people's pathways, learning disability pathways, physical disability pathways, and then wanted to send them through into a new pathway that was just about reablement. And in planned and urgent care, they wanted to create post-discharge pathways from hospital, looking specifically at social care impacts. So what you can do with those generic pathways is you can break them down into as many sub-pathways as you like. I think we can do actually about 1,000. So that you can look at individual parts of your system and then you can relate it all back to the whole of the system. Now their overall model ended up looking like this, and the sorts of solutions that they wanted to look at was what's the impact of having a single point of access, what's the impact of increasing reablement services, and what's the impact of looking at our community health and social care services together. I'm just going through some of these to give you some ideas. In actual fact, the results for Gloucestershire were useful. They showed them how where the costs would fall if you implemented any of those scenarios. So in some cases the benefits accrued to healthcare, in some cases to social care, and it was enabled. It enabled both sides to have a dialogue about how to manage that between them. The case study you can see at the moment on the screen comes from NHS Grampian. They were planning their capacity for scanners, and the questions you can see there was a demand for additional scanners, and what the health board wanted to do was to understand really what the demand was likely to be, when they might need to make that investment. And they were looking particularly at demographic change impacts, and also the fact that more and more clinical procedures were expecting to be using scanners over the next 5 and 10 years. So they built a model here, and you can see the different steps that they created. So the likelihood in both scheduled care and unscheduled care of needing either MRI or CT scans, and they built that out so that they were happy that it was producing the right sort of data that they would expect to see on an annual basis. And then they tested through a number of scenarios looking at what happens if with just population growth, and you can see the results there for their CT MRI scan, not a huge increase. And then what happens if the clinical practice starts to increase the use of scanners, and then what happens when you put both of those things together. So they could start to see their different demands. What they then did was they looked at the resource that they had, so they looked at their capacity for scanners against their demand. So they modelled that through, and you can see that those numbers start to go up and queues start to build within the model, and the sort of utilisation of the MRI scanner over that period. And what they could see was when they, in year 5, they had a sort of point when actually everything reached 100% and you couldn't do any more, you couldn't carry out any more activity, so that you would need to add a scanner at that point. And then there was another crunch point around year 8 and another one at year 10. So they were trying to understand at what point they would need to invest in new scanners. And then they had a look at what would happen if scanners were operational 7 days a week. And again, they could see that in fact they would only need to then introduce a new scanner in year 8. So that was helped them to make some of those decisions about when they would need to invest. And then I wanted to talk to you about the virtual ward scenario, which was a piece of work carried out in NHS Fife. And their question was, what happens if we implement the virtual ward? What's the impact on our inpatient bed capacity, our community hospital capacity, on reablement and social care? And they built their pathway to look at how over 75s medical inpatients move through the system. So they looked at both types, both surgical and medical inpatient admissions, but the ones that would be cared for by the virtual ward were actually those medical inpatient admissions. And they ran a number of scenarios to test the number of inpatients that might be appropriate for that service. So the first thing they did was to validate the simulation. So this is one of the very important things to do. Obviously you want to make sure that your simulation looks like real life, so that when you test it with new scenarios, you're fairly convinced that actually you're working from the right baseline. So they did some Hindcasting. They modelled forward their activity from 2008 to 2010 with their 2008 population, and they could see that the results from the simulation pretty much mirrored the number of acute medical admissions, and so they were confident that if they then ran that forward for another 3-5 years, then they would expect to get some reasonable results from that. The results that they could see were the number of emergency medical admissions per year from their base case. So if nothing was changed, what might happen? And then what they wanted to do was to understand what would happen if they developed a virtual ward at a certain point in time. You can see that's in 2012 and the beginning of 2013. You can see how the numbers of bed requirements drop as a result of that virtual ward. But because of the increasing population, you can see also that that starts to build to similar levels over time. And they tested a similar scenario with the assessment unit working 7 days a week as opposed to 5 days a week, and they were acutely aware that, of course, if the assessment centre was only working 5 days a week, then outside of those periods any admissions would go into an inpatient bed as usual. And so that enabled them to look at the number of beds that they would need each quarter for emergency medical beds, and they looked at that for both their over 75-year-olds and for their over 65-year-olds. So some of their learning is listed there. It helped them to understand the capacity demand and queues, and when the queues would be likely to start if the resource for virtual wards is finite, which of course it would be, what the impact on inpatient beds would be. And their advice was really always start a model very simple and then make it more complicated as you work through the problem, rather than worrying too much about getting the complexity right in the first place. Start with a simple baseline and then work it up from there, because you gain so much learning from that process, so it's all beneficial at that point. And then the final example I wanted to show you is an example of a disease pathway. This is in prostate cancer, with the questions being how many people are likely to need treatments each year, how could it be delivered more effectively, what's the financial impact, and particularly looking at breaches in waiting times and how you could avoid those. So the high-level pathway was developed looking at people turning up at their GP with symptoms, being referred on to urology and the treatment, and obviously the key waiting time targets were looked at there. And here's their initial diagnosis pathway, with people coming in from the start and then moving forward into the different parts of the system to their first treatment. And that's of course where you're going to be measuring the wait times for diagnosis and treatment. And here's the treatment pathway. And one of the questions they wanted to model was what happens if our GPs have a LES and start to provide some of this treatment instead of them going into outpatients. Does that free up our capacity? So they ran through the model, and what they looked at a particular population, the disease-bounded prevalence and the annual demand based on the ICD-10 codes. And they had 80 appointments in their outpatient clinics, which was dealing with both first follow-up outpatients and also treatments. And they validated the current state, and this is the sort of data that they needed. And an analyst and clinician signed off the initial results as being a reasonable representation of what was going on. And I'll come on to some of that validation, those validation questions when we look at scenario generator. So first question was, well, what happens if we introduce a second PSA test in primary care rather than everyone going on to secondary care after the first positive PSA? Now, they didn't expect that to happen for all patients, so what if 2/3 instead of 1/3 of patients have a second PSA test in primary care? So the before scenario you can see here, so here's the treatment pathway, you can see some of the numbers in it, and you can see where people are waiting in that scenario, and you can see here the time in the time that people are waiting. So it's you know, really not good enough for that 2-week wait. After the PSA, you can see that what we can see is that people are waiting a much more reasonable time, and also we can sorry, this is still before the PSA, and we're looking now at the treatment time to treatment. So this is this first treatment here, and you can see that that's about 67 days. So after we've introduced the second PSA in primary care, you can see that the waiting times go down both for treatment and also for the initial diagnosis. So that helps. But the other thing that they wanted to have a look at was what happens if the GPs carry out treatment after that first treatment. So of course they're going to be using some of that same resource, the outpatient consultant resource, which is under pressure really to do that initial diagnosis and treatment. So what's the overall impact of that? And this is where they modelled it. So you can see you've got arrows coming out now to a GP service as opposed to a secondary care service. And you can see the wait times now go right down. So users were able to understand what the impact on their resources would be of introducing these new changes. So I hope that's given you a bit of an overview of what sort of questions Scenario Generator can help to answer, how people have gone about developing their scenarios, and what I want to do now is to come on to using Scenario Generator itself. So again, just to remind you, anybody who's got any questions, please do post them through, and we're also happy to take questions afterwards if you want to email them in individually. So I'm going to take a stepped approach to this, and when you're starting to use Scenario Generator, step one really is to ask what is your simulation question. You could of course set up flows to represent your system and play about with them, but a simulation is really only useful if it's answering a question that you have. So define your question first, and the one that I'm going to use as we go through this process is to look at what happens if more community services are available to support people with an urgent care need, and this is prior to an emergency admission. So it's actually a very, very simple simulation we're going to do, really just as an example of how you might use it. Now let's just have a look at the simulation tool itself. So here's Scenario Generator. Now when you open it up, it will generally open on a mental health pathway, and on the right hand side of the screen here you have a set of pathways that you can move between. So here's our mental health pathway. If I double click on urgent care, you move through to the urgent care pathway. Here's our planned care pathway, which is all of our elective flows. Unplanned is in fact maternity, and we have an unsigned pathway which you can use to take activity from some of these pathways into other pathways. You'll notice we don't have a social care pathway in the original version. So let's have a look at what these mean then. So here's your pathway. We have flows going from the start of the pathway through to each of the possible services that people might want to use. So you can see a number of services here, and I'll just show you that we have updated some of this in our most recent version for 111 calls, for example. So the way that we set up these pathways is through a set of flows. We've used national data to set the proportion of activity that's likely to move from one part of the pathway to another. So if you run it through with your local population, it probably won't be quite right, but it shouldn't be too far away, because it will be close. It would be as if your local population were the national average. So you'll need to do some tweaking to it, but it shouldn't be too far away from the default, which should make your validation easier to do. So you can see that the pathway is made up of a series of steps, and if I just double click on one of these steps, let's have a look, let's do A&E, the emergency department, you can see that there are a set of properties within each of these steps. So I can click on cost here, and I can put in a cost for that service. I can also select from different costs here, and I've got default data uploaded so that we've got HRG4 now in the tool, so that you can look up different costs. And we've also uploaded the PSSRU health and social care costs, which cover community and some social care costs as well. So rather than worrying about whether you know the cost or not, you've got some defaults to choose from, so you can start running scenarios and then you can check them through with your finance department as you get more into the problem that you're modelling. You can also set a duration, and in this particular case we've got a normal distribution for days, but you can set days, hours and minutes, and you've got different distributions that you can choose from for the length of time that somebody might spend in that particular step. You've also got referral rates coming out of this, so you can say, well, the proportion of people that leave A&E at this point is 50%, and the rest go off to have diagnostic tests. And if you wish to, you can allocate a capacity to this. So if you had we've got different capacities and ways of defining those capacities, you can associate them with that step and also associate them with other services that are using the same resource. So that's how the steps work, and you can see there are slightly different icons on the screen. So this diagonal here is a step which has got no duration associated with it. It automatically corrects itself and sets itself up as a diamond, so you know. The green arrow is where all the activity comes in, so from your population, that's where everything's going to start. The red arrows are what activity is urgent, so they'll always be prioritized. The yellow arrows will be next in line, and then the grey arrows will be routine. And the thickness of the arrow denotes the volume of activity flowing through that step, so you can have some sort of visualization on that. There are some steps that have got a stop sign on them. That's because that's where the activity stops, so it's going to stop there and go out of the model. You've also got some other steps with a C. In this case, it's got a no-go sign on. That's because we've got some beds associated with it, but at the moment we're running that without the constraints of our beds, because we want to see what would happen if we had as many beds as we needed. Actually, how many beds would that require? What sort of bed occupancy would we get? So we can run this unconstrained by our resources, and then we can constrain it and understand the impact. So that's how the pathways work. I'm just going to give you a quick look at the unplanned pathway. We've got these ovals which represent weights in a pathway. Now, of course, if you're in the maternity pathway, you're not going to go straight from conception through to birth within minutes, so we need to be able to hold patients in the system for a period of time. So what we've done is we put weights between the different appointments to represent the amount of time that it takes for a woman to go from conception to birth. So we've set it up so that by the time you get to the birth, you're sort of around about 40 weeks, a bit less for some, a bit more for others. So we've got the proper representation, because of course people will conceive at all sorts of different points in a year, so you won't see all of those live births in the same year as which they're in the pathway. So it enables you to model that kind of passing of time. Okay, so that's how all the steps are created. This is how all the pathways are used. If I just go back to my slides here, and the next step, once you've decided your question, is to decide which pathway you want to use for the question you're going to model. Do you want to use all pathways? Is it a whole system, includes absolutely everything? Is it perhaps like Gloucester, where they didn't use mental health and maternity? Or is it only one pathway? Or is it a sub-pathway? So in our case, we're just going to be using the urgent care pathway to look at what happens if we provide more services in the community. Now, what you need to do is to have a look at some of the steps in that pathway. So let's go back to the model and look at the sorts of steps we want to think about. So I'll go back to the urgent care pathway here. Now, the question we want to have a look at is what happens if people have a community service which might stop an attendance. And this might be for patients who actually are known to the system, who are identified, and who can be referred to an alternative system. So we're only going to take patients who have come into primary care with an emergency, and instead of sending them through to some sort of referring them on to attendance, we're going to set up a new service for people to access. Now, in this pathway, that's the bit we're concerned about, because if you have a look at how the flow moves from primary care, it goes to an attendance. Now that might be an MIU or walk-in centre attendance. It might be an A&E department. From that, there's also a whole set of probabilities about how people move on to likely admissions, and then from admissions through to discharge, and the different sorts of services that people might need, and indeed social care. So we want to understand the impact of developing that service, and also the knock-on impact of having the service having that service on the rest of the system. So what I'm going to do is I'm going to draw in that intervention. Now on the top here you can see a couple of icons. Now what you can do is to drag them onto the screen and then set up your flow. So I'm going to call this step community service. So it'll probably be a community nurse that delivers that service. And I'm going to say that the cost of that service is £50 every time you use it. Okay. Now I'm going to draw an arrow from my primary care step to my community service. Now of course it's not quite as simple as that, because probably that community nursing service will need to see people a couple of times before to make sure that they don't need to be admitted. So what I'm going to do is to set up a way of modelling multiple calls or visits. So this will be my discharge step. And I will also have this wait step. So what will happen is people will go and wait for their service, and I'll just set up how long they will wait. So let's say for that sort of an emergency avoidance, you would probably only want people to wait. Once they'd seen the nurse, the nurse might need to come back perhaps within a day, maybe within 7 days, but perhaps let's say typically for 2 days. So that's the time people will be waiting between their visits. So they're going to wait there. I'm now going to send them back into my community service, and then there'll be a probability of discharge. So if I go back to my community service now and look at the referral rates, let's say, just for simplicity's sake, that 50% of people are discharged and 50% of them will go back for a further visit. And you can see that it's quite easy just to make those changes and to test it out. Okay, so here's our new steps set up. This is our alternative scenario, and we're ready to work out what might the impact be. But the first thing we've got to do is to validate our system, so to make sure that when we're testing our new scenario, we're testing it on the basis of something that is reflecting real life. So we've added our community steps here. What we need to do now is to generate our demand so we can see what the current activity looks like. So what we're going to do is to select our population, check our disease prevalence data, and then see what sort of demand that gives us. So what we're going to do is to find our population. So I'm going to look for the population input manager, which is under the structure menu here. Now, as I said, we've only got PCTs in this particular version, but we've updated that with CCGs now. I'm just going to choose the first one that we've got there, which happens to be South Gloucestershire. Now, South Gloucestershire PCT, this was the data at the time. you can see that the population is split down into different age bands, and there's also births and deaths modelled. And what that allows me to do is to have a look and see how the population is changing year on year. So if I was to run this through for 2 or 3 years, that's the population data that would be being used. Now there's you can see here there's an import and an export button. So if you're in South Gloucestershire and you were on the old version of Scenario Generator, you can just export that data, import your new, put in your new data and import it again, and that's you up to date. We've also got life expectancy here. Really what this is modelling the proportion of deaths in each age band. So again, you can make any changes to this because as the model rolls forward year on year, we know the number of deaths, but also we want to be able to model the proportion of deaths from each of the age bands. So that's our population in the model. We've also got disease prevalence in the model here, which allows you to, what that age-banded population is going to do is to take on the characteristics of the disease prevalence. So what we're looking at is the whole of the ICD-10 range. Now, each individual has a probability, depending on their age banding, of having one of these diseases. So what we model actually in Scenario Generator is the activity that's generated by those individual people rather than the individual patients themselves. So if you're Mrs. Brown, you might have an urgent care need and a baby and a mental health problem all in the same year if you were very busy using health services. So the activity generated is going to be in different pathways, so you could be simultaneously in different pathways. So you can see the data here that we have for disease prevalence, and you can check the different chapters. We've actually got all of the codes there, but the Royal College of GPs database doesn't include data for absolutely everything, but it does include really a very wide range. And you can see that in many cases, as you get older, your probability of having that condition increases. So that's what's being used. You can see also here that it's being split down between planned care and urgent care. So a proportion of this activity will end up in the urgent care pathway and a proportion in the planned. And again, you can change that. And there's also a multiplying factor. So we know that because the data has been taken from GP databases, there's a degree of disease which is not known to the system at all, which is undiagnosed. So we multiply that up to reflect that those additional conditions, and then we send them off to self-care. And we also send some activity off to self-care because although some people do go to the emergency department when they have a cold or a cut finger which could have been dealt with perhaps at home, sometimes they do go. So we have to include everything. So what that means is we have quite a lot of activity, which is far more than your population, and we send that off into a self-care step. So that's how we put our population into the model. I'm going to just select this individual pathway to run. So I can run all of my pathways, or I can just run this individual pathway, and that's what I'm going to do. And then I'm going to hit the run button. So as we run through, there's a clock at the top here. It's going to scroll through the weeks. We're actually running for a warm-up year because obviously you don't start your system with empty beds, so to make sure there's some activity in the system already, and then we take the results from the first year after that. So I'm going to close this high-level display. And what we can see now is there's activity in the system. So when you're validating your pathway, if you were looking at this urgent care system and you were in South Gloucestershire, say, you'd want to check your population, and then just to validate that you thought you were getting the right sort of level of results, you'd probably want to check your emergency department attendance. you'd want to check your emergency admissions, and it may be that you don't know that much more than that. You can check some of the other areas, and some of those might be important to you, and it depends what question you're answering. But I would check some of the kind of key areas first to make sure that you think your model's giving about the right sorts of results. Now you can see there's a little green blob turned up on the screen now, and if I just double click on that, you can see some further results on the screen. So in this particular case, I can see how much activity has come into my emergency admissions and how much has left. So obviously when we're looking at the end of this year one, you've still got people in bed, so not everyone has left. And you can also see some very useful results. You can see the peaks and troughs of demand over the year, and you can see the average occupancy. So on average we're using 599 beds, but of course in peak periods that's going to just over 700. Now that's useful information because although at some points you're under 500, at peak times if you only had 600 beds you would be struggling, so you're probably going to need more than those 600 beds if you don't want people to be waiting too long. Okay, so that's given us our baseline scenario, which is enabling us to see what the baseline is. So let's suppose that that is correct, and we want to run our scenario from that. So that was step 4, generate your demand. Step 5, run the scenario. Now, one thing I just wanted to refer to was when you run your scenario, we've just done one run here, but you can run your scenario multiple times, and that gives you a range of answers. That's very important because what we're using is percentage referral rates, we're using distributions for length of stay, and we know that probably our data isn't always that correct, and that there's a huge amount of variation in the health service. So if you run the same scenario multiple times, you get a range of answers, and you can take the average from that, the mean, and then you can look at the confidence intervals around that, which is very helpful because you're likely to need to plan for a range of results. So I would always recommend that you run that, and that's called running a trial. So we've been looking at and checking our results to validate them, looking at the volume of activity in each of the different services with the question that is this a good enough reflection of the system? Do I trust this enough that I'm now going to run some new scenarios? And really, if it's not good enough, then you might want to go back and check your population. You might want to check the flows of activities through. So, for example, if you're getting, if your visits to the emergency department are too low, then it might be because you're getting more referrals through from ambulances. So you might want to check the proportion of ambulance arrivals and whether that reflects the flow from the ambulance service. You might also have more people who just turn up. So what you would do is go to those steps and just increase the percentage of activity going to the emergency department and run that through again till you got the right result. If you still didn't have the right number of admissions, your admissions are going to be dependent on the number of emergency department visits that are admitted. So you would need to then change the proportion of people leaving the emergency department to go to an admission. So each step is dependent on the last step. So that's how you would need to change your flow, and you would simply do it by looking at your referral rates. Okay, so let's run a scenario now. What we're going to do is to look at that scenario of more people who go to primary care who would otherwise have been referred on to emergency services, well, the hospital really, emergency services, or walk-in centres, being referred to a community service. So a community nurse, we're going to say, costs £50, and we want to have a look at the impact on admissions, the impact on finance, and the cost of the service itself. So let's go back to our simulation, and let's just take a note of that number of A&E attendances, which is 79,212, and our admissions, which are 23,628. So we can have a look at the difference that we're making. And I'll just reset this. So the reset button here enables you to take all of those results off the screen so that we can start again. Now I'm going to rename my scenario so that it creates a separate file to allow me to compare my results. So I'm going to call that Scenario 2 South Gloucestershire. So when I run it through again, I have to look at that file, and I can compare it with my original. And I'm going to set up a new referral rate. So I'm going to say let's have 10% of activity that previously went through to attendance, now going to community services. Okay, so that's our change, very simple, and I'll just run that through again. So I'm going to close the high-level display here, and we can now have a look at our services. Now, what that's meant is that we've actually got quite a high number of visits in our community service. The knock-on impact on our A&E, so that previous number was 79,212, it's now 76,564, and our admissions have dropped by about 1,000. And if I double click on this, you can see that where my my average occupancy previously was just under 600, now 577. So that gives you a bit of an idea of what we've done here. But let's also have a look at the results. So I'm looking under the scenario results at the top here now, and I'm going to go to scenario comparison, and I'm going to pick up my scenario 2 with my original scenario. I'm just going to have a look at the difference in cost. So actually, by doing that, we've saved ourselves overall around 3 million, which is very good news. And if we wanted to have a look at the individual cost of that service, I can go into each of these different areas now and look at the different services. Let's find my new service here. And the new service is actually going to cost me 297,000, just over 297,000 to run. So if that was my service improvement intention, it's looking very good, and it might be well worth investing to look at the overall impact. Now, I said that was a simple simulation, and then as you look at that simulation, probably what happens is a whole set of other questions occur to you. That is quite normal. Like, for example, well, I don't expect every person going to the community service will actually not need an admission. It might be the nurse says, well, in fact, they really do need to go. So you might think, right, well, I'm going to have a proportion of this group, in fact, going through to the emergency department, which will mean that you're paying for that service, but they still end up using this service. What sort of difference does that make? And I'm sure you can think of a whole set of different types of questions that you might want to be asking. But I hope that gives you a bit of an insight as to how you would build that particular scenario. So a couple of other things that I wanted to just give you some insight into is you know, one of the questions might be how many community nurses will I need to deliver that service, and let's say they were able to take on 50 calls, visits per week each. What would their utilisation be? And the way that you would do that, I'll just show you how to do it. It takes a little longer to run this because obviously people will be waiting for that service. But what you can do is to set up a capacity, and the way that you do that is by going to your resources and setting up a capacity. So I can set up 5 community nurses here. I can say that actually they can do 50 activities a week, and once that's finished they can't do any more, so that's the constraint. And then I can associate that resource with that particular step. So this is my new team I'm setting up, and here they are. So when I run that through now, I can see how many are likely to be used and whether that 5 is a good number, and bearing in mind that they'll be doing other things with their time other than those calls, what's their likely utilisation. And I ran this one through earlier in Blue Peter style, and you can see I've now got results here for their utilisation, which is around 45%. Now you might say, well, that's really you know, we probably don't need 5. Actually, we could perhaps get away with 4, even 3. You probably want to test that scenario and see what happens. But you'd also be thinking that obviously the nurses wouldn't be working their total amount of time face-to-face taking calls. So actually, how much of their time would you expect anyway to be utilised by that? So those are some of the questions you might want to have a look at. And then the other thing that you might want to think about is we've run this model with a whole population, and our total emergency care. But you might say, well, actually, yes, that's fine, but in fact, I think it's probably only going to be those patients over 65 that are likely to use this particular service. So what I want to do is to create an over 65s urgent care pathway, and let's set that up now. So I'm going to copy this pathway, and I'm going to call it urgent over 65s. And you can see it appear here. Now, this is exactly the same pathway as I've created before, but what we're going to do is just associate. Oops, sorry, pressed the wrong button. The over 65s with that. So I'm going to choose this allocate ICD conditions to pathway step, which is going to load all my conditions, and I'm going to click Assign Conditions, and then select the generic pathway that I want to use. So this is the whole of urgent care. Now what I'm going to do is to select all of those conditions that might go into urgent care, and I'm going to take out the age bands that shouldn't be in this pathway. So there they go. And then at the bottom where it says select pathways to assign ICD conditions to, I'm going to send them to the over 65s, and then I'm going to assign them. Okay, now what that will do is just run the activity through my over 65. So let's just do that. So I'm going to select the pathway to run. I'll just check the over 65s, and I'll run that through again. And of course you can break those pathways down into as many sub-pathways as you like. So if you prefer to look at it for stroke pathways, for example, or individual diseases, you can do that as well. So here we are. It gives me the number of people. If I was just looking at the over 65s, the amount of activity I'd see in that community service, the number of admissions, and the impacts. So what I hope with this presentation is that I've given you some insights into how you use Scenario Generator, how other people have used it, a quick sort of 10-step way of using some of the key features in Scenario Generator that will enable you to get started. You should have a manual for this that you were sent to use this program. So please do use that. Please do ask us any questions. The details are there for you to contact us, and if you need any further training, and let us know how you get on. We'll be in touch with people just to see. We don't want you to be struggling. We're also really interested to know the sorts of questions that you wanted to ask, and you know, how you're getting on with them, and to be able to share those with other people. So I'll stop there. There's a couple of questions, but I think it's 12:10, so I'll get back to those with those people individually, if that's all right. I hope it's been useful. The session's been recorded, so if you would like to pick this up in your own time, go back to it and use it for your own your own use, and to go through it again, please do. And if you want to pass it on to colleagues, then please do. So thank you very much indeed for your time today. Good luck with using it, and do keep in touch.